This is not a video about pulp caps. A decision has been made to do a vital pulpotomy using MTA. So first of all, tooth isolation is critical. You can decide whether an isolite or rubber dam is better for you, but do one. This is for the safety of your patients and the success of your treatment. If you feel like you can't do either, then I suggest just reevaluating your treatment plan. Here we're using a high-speed round burr number 6, and I do use a 169 burr for interproximal slicing or any other fine-tuning. So I like to visualize a rectangle. Here we have a mandibular primary second molar whose pulp chamber basically looks like a rectangle. So I really like to use the pulp horns to kind of connect the dots. And I have a pulp exposure here. And this is actually a good example of how pit decay in primary teeth can quickly become a pulp exposure. And take note of how close the mesial pulp horn is to the tooth surface. Control the bleeding by packing a lot of cotton balls. This is a technique I learned from Dr. Jack Frick, a retired pediatric dentist. So here I am putting a lot of pressure and adding a lot of small cotton balls to my pulp chamber. During this time, I'm constantly assessing the health of the tissue. Is there tissue? It should look like clam meat. Is it just blood? A young patient, we're talking 3 and younger, will tend to have a large pulp chamber. So is the bleeding appropriate for the age? And I'm constantly just going over these questions in my head again. Has the patient been in pain? Is this an inflamed pulp? Should I broach the canals? So here I am, just removing the cotton balls and doing this assessment in my head. This amount of bleeding is okay and acceptable. And sometimes I do go ahead and leave a cotton pellet in the chamber. Here I am with a spoon, just removing the tissue. I'm still asking myself, is this the right amount of bleeding for this young patient? And I do have some cotton balls that are soaked in saline that I will use, and I do not use anything that is cytotoxic, such as bleach or anything else. And here are my saline-soaked cotton balls. And I'm trying to visualize the canals as I do this. I'm checking to see if I have any tissue tags left behind. And it's around this point when my assistant is mixing the MTA. It is easier for the assistant to transfer the MTA into the amalgam carrier if the MTA is a little bit more wet. So here I am. I've decided that I'm going to finish unroofing the pulp chamber in the mesial buccal corner, which is my weakness. And then here I am with the dry cotton balls, just constantly reassessing how clean is this? How much bleeding really is happening here? And you can visualize some pulp radicular tissue in the distal root area. And I'm just double checking, making sure that I don't have any tissue tags left. Getting my dry cotton ball again, just cleaning up all of the blood. And every time I use the cotton pellet towards the orifices, I am using a lot of pressure. And so here's my first transfer of MTA. I'm going to grab a dry cotton pellet to pack it down as best as I can. The whole time I'm still doing an assessment. Is the MTA completely pink? What does this look like? How is the oozing? And so I've decided that this amount is acceptable. I usually like to use GI on top. I know that some people do use IRM. It's whatever you prefer. But when you do place and pack the MTA, you can pack more than the 2 millimeters that is recommended, but you just have to leave adequate space for your glass ionomer. I am continuously using the dry cotton ball just to pat everything down, and this is a crucial step. You need to make this as clean as possible so that radiographically it is clean also for the next doctor. I'm using my condenser to pack everything down, and I'm also using the condenser to kind of scrape over the excess from the walls just to make everything clean. Glass ionomer is great. If the crown is lost, then the material is intact and you have your quintessential black MTA staining that's very typical for the material. But I always felt pretty confident when the patients did lose a crown and when the patients came in with the GI intact. So at this time, my assistant is mixing Fuji 9. I like to use the mixing Fuji 9, and I do use Keetac molar that's in a capsule. I just always preferred Fuji 9 because the assistant can mix it very, very thick. And when you have a behavior management case, then it is easier for me to quickly place it and have the procedure done. So I'm just looking around, just making sure everything's okay while she mixes that. I do have a crown ready to go, and so after the GI is set, and that's when I'm going to go ahead and put the crown on. So here I am placing the Fuji 9. And then I'm going over it one more time with my condenser.